Greetings and a warm welcome to all the dignitaries present here. I'm Rimpa from Clernit, serving as the allocated session assistant to ensure a seamless experience. Clernit proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clernit serves as a digital partner for this event hosted by Indian College of Anesthesiologists, and the focus of today's session is Mastering Anesthesia for Liver Transplantation. Now, I would like to invite Dr. G V Premkumar sir to proceed. Over to you, sir. Thank you.
Thank you. First of all, I would like to thank the Indian College of Anesthesiologists, its president, Madam Jayashree Sood, whom I am greatly indebted to, because of whom I was able to come to liver transplant anesthesia. Because she was the one who chose me 20 years back to come to this field. And what I am is because of her. And we have three eminent speakers who are doyens in the field of liver transplant anesthesia. So they will be talking on liver transplant. So liver transplantation is a very complex surgical procedure, and it involves the replacement of a diseased liver with a healthy liver, which can be either from a living donor or from a diseased donor, which can be a brain dead diseased donor or a circulatory diseased donor. So the first successful liver transplant in India was performed in way back in 1998 at Apollo Hospital. And we are very proud to know that that baby, who was about 20 months old, is now a full-fledged MBBS doctor. So our first speaker is Dr. Sunil. He would be speaking on the anesthetic management of minimally invasive donor hepatectomy. Dr. Sunil Kumar is Senior Consultant and HOD Liver Transplant Anesthesia at Star Hospitals, Hyderabad. And coming to minimally invasive donor hepatectomy, as you all know, all the surgeries are going towards minimally invasive these days. So there is use of laparoscopic and robotic techniques to extract the donor liver. And it initially evolved from just a small left lateral sectionectomy, and currently it has extended to all right and left lobe hepatectomies. The rationale is to enhance the donor safety and the quality of life in living donor liver transplant donors. The advantages being reduced pain, better cosmetic outcomes, shorter hospital stay, faster recovery, and lower wound-related complications. However, there are challenges associated with it because there's a steep learning curve, and it requires high technical demands, and there is need for advanced imaging and navigation. The current status is that it is adopted by many large volume centers worldwide, and the increase of robotics is keeping on increasing day by day. And the outcomes are comparable to open surgeries. So over to you, Dr. Sunil.
Good evening, respected seniors and my dear friends. I will be starting my presentation. Sir, is it seen, sir?
Yeah, we can see. We can see
clearly. It's slideshow.
Okay. So the topic I'll be speaking on is anesthetic challenges in minimal invasive donor hepatectomy. Part to minimal invasive, the marked imbalance between the escalating need for liver transplantation and the platelet availability of quality of diseased donor organs remains as a primary and continual stimulus for living donor liver transplantation. In many Asian and Middle Eastern countries, cultural issues further compound the challenge and render LDLT as the only viable option for those with advanced and life-threatening liver diseases. A commensurate expansion of LDLT to offset this disparity is yet to be actualized in most countries due to concern related to potential negative impact on living donor hepatectomies, which may have on donor safety and quality of life. donor hepatectomy has undoubtedly remained the most sensitive application of the minimal invasive approaches. The subsequent application of this innovative approach to living donor hepatectomy has been deliberate and began in Paris with Cherchez et al. In 2002 report on laparoscopic left lateral sectionectomy for donation, which was later followed by a 2005 report from Northwestern wherein Coffron described how laparoscopic assisted was utilized to perform a right donor hepatectomy. In the last 15 years, minimal invasive donor hepatectomy has evolved into a well-established clinical endeavor with a clear intent of mitigating the short and long-term complications that plague living donor liver transplant undergoing conventional open donor hepatectomies. There was a consensus being done in 2019 with the aim of establishing the clear recommendations for the safe, widespread approach of minimal invasive donor hepatectomy. And to conclude with this consensus was, it has produced a set of clinical guidelines based on the availability of evidence and clinical expertise. These guidelines are presented for safe implementation and development of minimal invasive donor hepatectomy in LDLT centers with the goal of optimizing donor safety, donor care, and recipient outcomes. This is a wide survey of minimal invasive donor hepatectomy global snapshot, where we can see that the right lobe being done more of 1500 cases, left lateral being 400, and left lobe being 366 cases. Coming to the worldwide, the Asian countries doing a large number of LDLTs and laparoscopic minimal invasive donors hepatectomy, which comes up to 1700. Europe, Middle East around 300, and American countries doing around 245 cases. There are various modalities of minimal invasive in which pure laparoscopic are 1200, robotic are 180, and hand assisted is 1000. It is a high volume surgeon preference where there is decreased portal contraindication, decreased arterial contraindication, and bile duct increased clip cut before cut. These lead to the minimal invasive approaches. The outcomes of these minimal invasive is no mortality, conversion rate has gone down to less than 5%, blood loss less than 250, and transfusion also less than 1.6%. There are different modalities of minimal invasive, such as pure laparoscopic donor hepatectomy, pure robotic donor hepatectomy, laparoscopic assisted donor hepatectomy, that is a hybrid approach, and hand assisted laparoscopy. So here we can see the laparoscopic donor hepatectomy where they have used the ports, and in this diagram we can see the chief surgeon standing at the foot end with the assistant and the camera person standing next to the patient. This is a robotic approach of donor hepatectomy where the arms have been kept and the procedure has been underdone. So donor hepatectomy is basically the part of the liver donor is being transferred and implanted in the recipient. Here we can see the scar marks, how the open donor hepatectomy where the reverse L incision was done. In some centers, they do midline incision also. And once we come to minimal invasive or such as laparoscopic, there's only a small phalansteal incision mark being present in the donors. The evolution in anesthesia in respect to minimal invasive. The minimal invasive surgeries offer several advantages over conventional. As said earlier, like shorter hospital stay, minimal scarring, less pain, less blood loss and transfusion, and quicker ambulation. There are several important challenges for the anesthesiologist, such as the patient positioning, limited operating room space, limitation of patient access, increased duration of the procedure, hypothermia, hemodynamic and respiratory effects of pneumoperitoneum, and occult blood loss which happens during donor hepatectomy. To select and implement a successful anesthetic strategy, it is utmost important to consider the interaction of the patient condition and functional status with the anesthetic technique and surgical factors. Anticipating and planning the movements and activities in the operating room are fundamental in management of minimal invasive donor hepatectomy. Hence, relatively large operating room is needed. Operating table should be used for lower lithotomy position or French position. Here we can see a big operating room compared to the normal one, where we have a slave monitor along with the monitor for the laparoscopic and other equipments being placed. Coming to induction and intubation for donor hepatectomy, it is a routine induction with taking care of little bit like inducing the patient with rapid sequence. This is because to decrease the gastric insufflation so that during surgery, gastric distension might not occlude the surgeon's field. And preferably flexometallic tube should be used so that because once we intubate and put the drapes and do long procedure duration, the tube might get kinked. So flexometallic tube would be better preferably. Here we can see the gastric bougie being placed in when we are doing this donor hepatectomies. This is because sometimes with the Riles tube, the entire gastric insufflation might, the gastric air might not get deflated, and hence bougie might be useful in doing these procedures. And because of this gastric deflation, the liver mobilization and the surgeon's feel will be much better. Routine arterial and venous access has to be placed like radial arterial line and central line and 16-gauge cannula for emergency purpose. Few places we also use dialysis catheter at the beginning of the program, and now we have shifted over to the central line procedures only, central line catheters only. Positioning of patient is very much important, and we need to take care like how we take care of other donor hepatectomies, because due to the long procedure there will be chances of pressure over the nerves and other pressure points. There are a lot of pressure pads being applied, like the boots which we take care so that the patient once in lithotomy position which we place and prevent any pressure source over the knee joints or other places. This is a photo of the beginning of the laparoscopic donor hepatectomy, where you can see that the head end is and the entire operating room, there won't be much space for the anesthesiologist or the technician to move around. This is the port insertion of the for the patient when doing the donor hepatectomies. And same, this is the diagram where this is a photo of when we are doing the transaction in donor hepatectomies. And here we can see that the head end, there's a monitor which has been kept. So our head end will be occupied with the monitor and other things. We'll be basically standing towards the right side of the patient and all the infusions being kept there. Ventilator settings. Unlike the normal or open donor hepatectomies, here we can keep a little bit modified ventilator settings, such as the pressure regulator, volume control, so that we can keep less volume, less pressure, airway pressure. And there is a lot of studies which says that less in airway pressure helps in decreasing in intra-abdominal bleed and other things. As you can see, there a lot of infusion pumps will be required, like the relaxation, the sedation, and just for emergency purpose, we keep some vasopressors during for the donor hepatectomy surgeries. Pneumoperitoneum is the biggest challenge for anesthesiologists because it can cause bradycardia, hypotension, symptomatic bradycardia, increase in airway pressure, and carbon dioxide embolism. The benefits of pneumoperitoneum is venous back bleeding and reduced operative blood loss. There's a study by Yung-Quing Lee et al. Which defined symptomatic bradycardia. So many times we see once there is pneumoperitoneum or in open donors, when there is retractor, there is bradycardia. Along with bradycardia, there might be sometimes hypotension also being happening. So that they have come up with a terminology called symptomatic bradycardia, means there is hypotension along with bradycardia that's happening. So hypotensive bradycardia is defined as when the heart rate goes below 60 per minute, associated with simultaneous mean arterial pressure going 65 millimeters of mercury. So when these two happens, then it is known as symptomatic bradycardia. This is mainly seen in laparoscopic living donor hepatectomies, which we also have encountered a couple of times. Another problem which we commonly encounter is the carbon dioxide and air embolism. Once they create a pneumoperitoneum and some vessels being opened up, sometimes sudden gush of carbon dioxide gets into their bloodstream, and there will be sudden rise in EtCO2 causing this carbon dioxide embolism. So what is the management of carbon dioxide embolism? first and foremost is to inform the surgeon that such a thing has happened. Then next is to prevent further gas entry, like discontinue the carbon dioxide insufflation, discontinue nitrous oxide or ventilate with 100% O2, and position the patient into left lateral decubitus position. Adequate hydration has to be maintained, and central venous catheterization, with the help of that, we can aspirate the carbon dioxide. Other resuscitation measures being fluid administration, and if it still not settles, then we need to go on using inotropes or vasopressors. And in extreme cases, hyperbaric oxygen therapy may also be required. So there are a lot of studies which tells us how to reduce the bleeding intraoperatively, like maintaining the intra-abdominal pressure bit high. So this study by Erickson et al., which showed that intra-abdominal pressure, if we maintain at around 15 to 16 millimeters of mercury, there will be decreased bleeding, but there is again chances of gas embolism, which we need to be vigilantly monitoring. There is another study which showed by Shin Kubasi et al., which showed that experimental monitoring of among airway pressure, pneumoperitoneal pressure, and central venous pressure in pure laparoscopic donor hepatectomy. So this study mainly showed about the airway pressure, pneumoperitoneal pressure, and CV pressure during laparoscopic hepatectomy. And they concluded that by reducing the airway pressure among all the three, that is the airway pressure, pneumoperitoneal pressure, and CVP pressure, by reducing the airway pressure, it has effectively controlled the bleeding, and it helps in venous back bleeding to reduce, and it is safer compared to other pneumoperitoneal pressure and CVP pressures. What is the role of CVP when we are doing hepatectomies? The current research shows that CVP is not reflective of central blood volume, and there is a general trend towards not utilizing invasive CVP monitoring to guide fluid therapy. So of late, they say that instead of CVP, PPV monitoring, which will be much more reliable because of the position of the tables and other things. Low CVP in this context refers to instituting measures to minimize the cable distension and tension. And it also helps in low hydrostatic cable pressure. Basically, it works on the Poiseuille's equation. The physiological basis of this beneficial effect of low CVP is found in Poiseuille's equation. That Poiseuille's equation means it is the difference between the pressure between two regions and the radius of the vessel. So blood loss from the vascular injury is directly proportional between the pressure gradient across the vessel wall and the fourth power of the radius of the injury. By lowering the CVP, not only it will reduce the pressure gradient, but also minimize the radial component. In this way, reduces the vessel distension and helps in preventing bleeding. So, what are the chances of bleeding? In the early program of minimal invasive, there will be a lot of bleeding happening, which sometimes be occult also. Along with so for counteracting this, there were a lot of bleeding issue protocols which institute-wise has been prepared. Blood requirement reduced as the program and minimal invasive approach from the surgeons has become more and more regular. Another important thing which we come across in laparoscopic minimal invasive donor hepatectomy is the ICG usage. So the ICG usage helps us in delineating the right and left lobe at the beginning of transaction. At the same time, it will also help us in the bile duct vasculature. There's a statistical graph which showed the relative comparison of anesthesia-related risk of complications for laparoscopic and open donor during different phases of the operation. So this is mainly like pre-transaction phase, transaction phase, and post-transaction phase. And we can see the risk of anesthetic complications are more during the transaction of the liver. So the surgical side in pre-transaction phase, pneumoperitoneum and liver mobilization sometimes causes the anesthetic complication, along with our side being muscle relaxation, monitoring of trocar injury, hemodynamic and ventilatory optimization has to be done to prevent those things. Same way, during transaction phase, vascular clamping, parenchyma transaction, and vascular clamping again causes anesthetic complication, which can be avoided by using overzealous fluid, hemodynamic optimization, and normotomia to be maintained. during post-transaction, there will be, during hemostasis, large of surgical field closure will be there. So monitoring of gas embolism and cardio and respiratory optimization has to be done post desufflation. This helps in reducing the risk of anesthetic complications. Analgesic part in minimal invasive donor hepatectomy. Intraoperatively, there are a lot of institute-wise protocols, like few centers uses fentanyl or ketamine, or sometimes they use epidurals, or sometimes the blocks. Post-operatively, since it's a minimal invasive approach, the requirement of analgesic will be little less, but it is not zero or very minimal. Hence, we can use opioid sparing by giving blocks, or PCA pumps can be used. This will help in patient satisfaction. So there is one study by Quigley et al., which showed the change in anesthetic management in open to laparoscopic liver donor hepatectomy after the learning curve. So they have modified their anesthetic practice also. Instead of using endotracheal tubes, they have started using LMAs in minimal invasive donor hepatectomies, and for pain management, they are using electrospine block. Same as I already said about the ventilators, they are using low tidal volume and PEEP. There is no central line access being used for this study, and they are going ahead with only peripheral cannulas. This is all because of the learning curve, and the duration of surgery is also very much reduced, and hence the anesthetic duration is also reduced. And there is no blood transfusion in the entire study which they have done. Post-operative beneficial of minimal invasive donor hepatectomy. It helps in improved recovery, reduce post-operative pulmonary complication, reduce narcotic requirements, and it helps in enhanced recovery, especially the minimal invasive approach. There is a lot of study which shows about the pre-operative oral carbohydrate administration. This helps in regeneration of the liver, as well as in preventing nausea, vomiting, and other laparoscopic or robotic pneumo-related complications. There's a lot of studies which are coming up with oral carbohydrate administration prior to surgery, 2 hours prior or at least previous night, which helps also in lactate reducing and liver regeneration also. Minimal invasive also helps in early mobilization, minimization of the bowel and bladder tubes, reduction of intravenous fluids, and early initiation of feeding. So the path forward for in minimal invasive is 3 decades of work and progress in minimal invasive laparoscopic surgeries, donor hepatectomies techniques, and LDLT have now merged in such a way that the paradigm shift in living donor surgery is materializing in the form of minimally invasive approaches. The impact of minimally invasive donor hepatectomy surgery is not limited to simply completing the operation with smaller, better position or more aesthetic pleasing incisions. Instead, the journey ends for minimal invasive will only reach its true potential when both the innovations and innovators synergistically join together in making living donation truly safer. The true greatness and the impact of evolving field lies in the degree to which it can be safely disseminated to the masses through collaborative partnership. If realized, this combination of enhanced safety and unrestricted practicality may lead to significant rise in liver donation and a new era in living donor liver transplantation. So a lot of donors come up when we motivate them for minimal invasive approach, which helps the donors for safety as well as aesthetic purposes. Innovation in surgical techniques and approaches can often require a prompt simultaneous innovation in anesthetic techniques and approaches, both of which are the basis for the progress in the field. So the surgical as well as the anesthetic approach have to be upgraded in these minimal invasive donor hepatectomies. These are my references. Thank you all.
Thank you, Dr. Sunil, for an excellent overview of the anesthetic challenges in minimally invasive donor hepatectomies and how to manage also minimal invasive donor hepatectomies and what are the birds of managing such cases. So now we come to the next speaker. Once we have heard about the anesthetic challenges in minimal invasive donor hepatectomy, the main problem which occurs is the pain management. and to tell us about the challenges in pain management in donor hepatectomy, both open and minimally invasive. Because the open surgery is a very huge incision, and we must remember that all the donors are healthy individuals and they are not patients. So the threshold for pain is very low. The goal should be adequate pain relief with minimal side effects for fast recovery and maintaining donor safety. It is a high pain intensity and there is a risk of inadequate analgesia, which may lead to atelectasis, impaired cough, venous thromboembolism, and delayed recovery. So a multimodal approach, including regional techniques and systemic agents, have to be used using the ERAS principles. So now I would like to call upon Dr. Prerna Shah, who is professor at KEM Hospital, Mumbai. And we are lucky that despite the heavy rains and all, she is still able to connect to us. Right? She will be talking and enlightening us about the pain management in donor hepatectomy. Over to you, Dr. Prerna.
Thank you, sir. Is my slide and am I audible?
Yes, your slides are visible, but you have to go to slideshow.
I'm already in slideshow. Still not in slideshow?
No. Double click. Yeah, now you are on slideshow.
Okay. Thank you very much, Indian College of Anesthesiologists, Dr. Jayashree Madam, Dr. Annu, Dr. Prem, whom we had gone at Gangaram Hospital, I think way back in 2009, when our institute decided to go ahead with the liver transplant program. So as in the previous lecture, we have already talked in detail about the impact of different types of approaches for donor hepatectomy. So we all know that donor hepatectomy is a complex surgical procedure. It can be open, where it is in a right subcostal incision or a reverse L-shaped incision is taken, or a laparoscopic approach or a robotic approach. Now, most the centers are going towards laparoscopic and robotic approaches. However, there is not yet any consensus on the best practice. However, the data is evolving and it is saying that the minimal invasive are the has a better outcomes. So as Dr. Prem has already said in the introduction, inadequate analgesia impacts the short-term recovery, long-term outcomes. It increases the morbidity. Functional limitations are encountered. There is dissatisfaction among the patient, impaired quality of life. It leads to increased or longer hospital stays, potential for chronic pain, and long-term opioid use, and obviously higher medical cost. Now, the mechanism of pain is either via the peripheral nociceptor stimulation due to the incision, rib retraction, and diaphragmatic irritation. And it could also be due to visceral origin transmitted by the sympathetic nerves. The common things which are used are just put in this slide for pain relief. In open, usually an epidural is inserted, epidural catheter, and 0.2% ropivacaine is given for 3 days, or followed or in addition to a tap block or IV PCA, and usually a multimodal approach is given. In laparoscopic and robotic approaches, there is port infiltration, incision infiltration, tap, and SOS if needed, then the intravenous PCA. Intrathecal morphine some institutes do use even intrathecal morphine. Erector spinae blocks and paravertebral blocks are the new upcoming things which are been used in some institutes, and there are few reports and case series about them. Or Paracetamol can be given in thrice daily. Some institutes or some reports are there of even using ketorolac. One important thing to be remembered is that the donor has will take some time for the regeneration of the liver to occur. So immediately post hepatectomy, there would be the liver size would be less, and that would lead to delayed metabolism of the drugs which would give. Hence, that should be kept in mind before giving your dose of drugs. Now, different protocols and approaches are there for analgesia in donor hepatectomy. The common ones are the enhanced recovery, that is the ERAS protocol. Then there is a PROSPECT, which is procedure-specific post-operative pain management. There could be some personalized analgesic regimens. There could be some psychological factors of the donors which could be involved in deciding what drugs to give. Patient-centered care on and the earlier post-operative pain experiences could also affect your management of pain. Evidence-based and multidisciplinary framework for perioperative care, and there could be few novel pharmaceutical agents. Now, in our eras, which is the most popular and commonly used by several institutes, we all know that it enhances post-operative recovery. It is a causes balance between the improving the outcomes with potential risk. So that's where the ERAS has become very popular. It involves preoperative counseling, nutrition, carbohydrate loading, and avoidance of perioperative fasting. Usually it is a non-opioid type of analgesia which is followed in ERAS. So that leads to early mobilization, minimizes surgical stress, and maintains metabolic homeostasis. It involves even multimodal analgesia, intrathecal morphine and all could also be one of the approaches which could be used. And there are some reports of dexmedetomidine infusion and liposomal bupivacaine. In the PROSPECT protocols, the drugs or the analgesia regimens includes NSAIDs, that's paracoxib 40 milligram, or it could be continuous thoracic epidural analgesia, subcostal tap blocks, IV dexmedetomidine, IV magnesium, intrathecal morphine, quadratus lumboris blocks, paravertebral nerve blocks, continuous local anesthesia wound infiltration, postoperative intraepidural local anesthesia infiltrations, acetaminophen or PCM, and systemic opioids as a rescue analgesic. So now we are going towards a trend where opioids are being used to a lesser extent as compared to what was being used maybe a decade ago. So these are the full domain of analgesia options which we have, which can be used to manage the post-operative analgesia for the donor hepatectomy. In a patient who has undergone laparoscopic or open donor hepatectomy, the pain would be really minimum as compared to an open surgery. In laparoscopic approaches, there would be minimal direct harm to the diaphragm and respiratory muscles. Hence, there would be decreased post-operative pain. This will further help in promoting deep breathing and active coughing during the recovery phase. It decreases in pulmonary complications, and there are reports and studies which say that opioid usage has been drastically less required till the post-operative day 7, and obviously all this leads to shorter hospital stay and saving in the costs. Now, thoracic epidural analgesia remains still as one of the gold standard for pain relief in open donor hepatectomies. Several institutes do still continue doing open hepatectomies. So it has the other important things which we need to remember is there is potential intraoperative coagulopathy which can occur after liver resection. Hemodynamic effects can occur due to intraoperative vascular clamping. Postoperatively, the elevated INR levels and decreased platelet count despite having a normal liver function before surgery can impact your removal of the epidural catheter. This can lead potentially delayed ambulation due to either hypertension or if you do not have those portable epidural pumps available or not affordable patients, then that cumbersome of a syringe pump and all that could further delay the ambulation. Risk of epidural hematoma and subsequent neurological injuries, although that is very rare. Unplanned delays in the removal of epidural catheters because of the coagulation issue, and the ERAS protocols where we are going away from opioids has led to the reduction in the use of thoracic epidural in recent years. It can be integrated into the ERAS pathways. So there are several studies which show of different drugs and different combinations which have been used. I have highlighted few of those. Mid-thoracic epidural catheter is usually what is inserted. If not, you can even insert at L1 too, but assume that, achieve your level of sensory block up to T4. So in mid-thoracic, then one case series shows fentanyl bolus of 15 microgram with 10-minute a lockout interval. Appropriate doses of local anesthetics in another study shows 0.15% bupivacaine with fentanyl 2 microgram per ml at the rate of 6 to 10 ml per hour. Then in another studies, there have been using 10 ml of 0.25% with 50 microgram of fentanyl, and with a sensory block to be reached at about T4, and they have used 7 ml per hour. So some have used between 6 to 10 ml is the average rate of infusion which is commonly followed, and some have even added propofol or remifentanil if available, or tramadol in addition to the bupivacaine. So there are several reports and meta-analysis available. So depending on your institute availability of things and resources, you can devise your own protocol. The next one is the IV patient control analgesia with morphine or fentanyl. It facilitates early mobilization, reduces respiratory complications, enhances patient satisfaction. However, there are side effects like post-op nausea, vomiting, sedation, itching, constipation, and respiratory depression could be one of the causes due to the opioids. So you should have droperidol or ondansetron. Either they can be mixed in the opioids or they can be given separately. One must remember this: all drugs are metabolized by the liver, and as a part of liver has been given to the recipient, so we should be very much we should keep in mind the duration, and will be different from a patient who is just undergone a hepatectomy and not a donor hepatectomy. Donor hepatectomy for some other reason where probably that part of the liver was already non-functional. So risk of accidental overdose with a small portion remaining of the liver is to be kept in mind, and that's the challenge in adjusting the dosage. Dexmedetomidine is a part of multimodal analgesia strategy. We are know that it's a highly selective alpha-2 receptor agonist. It causes sedation, hypnosis, anxiolysis, and also has the analgesic property for which it is used. It reduces perioperative stress and inflammation. It helps to reduce the opioid consumption within the first 24 hours as per several articles. It enhances post-operative analgesia. It protects patients from noxious stimuli. However, there is one cardiovascular response, especially bradycardia, which occurs if you are giving a bolus and loading dose. So if you start straight with, say, probably in maintenance dose of ranging of 0.2 to 0.7 microgram per kg per hour, this cardiovascular response of bradycardia is minimized. Sorry. Magnesium is also a part of multimodal approach. It is an antagonist and NMDA receptor. It inhibits calcium channels, thereby modulating pain and inflammatory responses. It could be an alternative or adjunct to opioids for pain management. It also reduces opioid consumption, especially within the first 24 hours. And it gives analgesia with minimal side effects. You usually give bolus of 30 milligram per kilogram, followed by 10 milligram per kg per hour. Ketamine is another NMDA receptor agonist which can be used as supplement to opioids. The low doses of ketamine results in reduced opioid analgesic needs. It enhances post-operative pain relief. It gives very low pain scores, enhances recovery, and reversal of opioid tolerance without any documented interaction with ketamine. So this probably, if you continue giving opioids, then the patients develop tolerance to it. So ketamine, if added, can help in reversing the opioid tolerance. Gabapentin, it's oral preoperative gabapentin is what is given. It requires about 6 hours to achieve the therapeutic levels. So it can be used as a supplementary measure to enhance the pain management. It reduces CNS sensitization. However, there are no available established protocol concerning the most effective dose and the duration of gabapentin. TAP block, now all these new blocks which have become very popular. So this can also be used for managing the analgesia in a donor after donor hepatectomy. So these are modern approaches, blockade of sensory nerves with neurofacial within the neurofacial plane situated between the oblique and transverse abdominis muscles. It causes effective post-operative pain relief. It reduces the need of perioperative opioids, maintains hemodynamic stability, and facilitates quicker recovery from anesthesia. Either it can be used by landmark or ultrasound. Ultrasound guided is the most common and preferred thing now. It causes somatic anesthesia of the abdominal wall, relies on interfacial spread. Visceral plane relief can be achieved through the use of NSAIDs, paracetamol, tramadol, and gabapentin. It is commonly performed in open or laparoscopic donor hepatectomies, and usually a bilateral oblique subcostal tap block is given. In addition to the tap block, you can give acetaminophen 6 hourly and other NSAIDs like paracoxib. You can supplement with dexmedetomidine and opioid as a rescue analgesia. Now there are different regimens of local anesthetic without opioids which are available in the literature. So perioperative, they say of different concentrations of ropivacaine are used by different centers. Some use 0.375 ropivacaine with a steroid. Some use bupivacaine diluted and then pass the tap catheter under vision, or surgically it is inserted. Some use 0.2% of ropivacaine, give 20 ml at both sides at the end of surgery, and then continue 5 ml per hour for 72 hours. 0.375% bupivacaine, 15 ml on both sides, followed before the incision, and then bolus is continued via the surgically inserted catheter. 0.25%. So what I'm trying to bring is that different concentrations have been tried and used, and one is more familiar, and the common desired range of infusion can be practiced at the institute. The another block which is few reports which are there are of the quadratus lumboral block. It's also a facial plane block. The local anesthetic is given near the quadratus lumboral muscle to block the thoracolumbar nerves. It causes extensive sensory blockade from T7 to L2 level. Even for the most cephaloid aspect of the J incision of the open surgeries. Some studies have suggested superiority of quadratus lumboral block over the TAP block. So ropivacaine 0.4% at the rate of 0.6 ml per kg bolus, followed by catheter of via the catheter 0.2% at the infusion of 5 ml per hour is given, and you can have a patient control where you can have a 15-minute lockout with maximum 20 ml per hour as the PCA option. Other block is the erector spinae block. So it gives analgesia in the abdominal region when performed at the lower thoracic levels. It targets a plane below the erector spinous muscle, which is superficial to the vertebral column and away from the major neurovascular structures. Hematoma at the erector spinae plane, if you have encountered it can be easily managed without affecting the spinal cord, as it is protected by the vertebrae. It has lower risk of causing, hence it has less risk of causing neurovascular injury. Continuous blocks have also been used, and it is found to reduce the need of opioids. Intrathecal morphine, single shot intrathecal morphine is practiced by some institutes. 400 microgram is given. It is simple, faster alternative with lower rate of technical failure. Increased risk of, however, there is increased risk of post-operative respiratory depression. It requires close monitoring in the ICU along with oxygen setup, and naloxone should be kept available in case there is opioid-induced respiratory depression. Thoracic paravertebral block is another options which few institutes and few reports are there. It is the right thoracic paravertebral block which is given. It can be used in whom epidural block is contraindicated. However, the risk of spinal hematoma is rare with the use of paravertebral block. Unilateral confers only ipsilateral pain relief. Rescue analgesia in the form of morphine is often needed. Hepatic clearance may be reduced with compromised liver function, as I already said, in a patient who has just undergone a donor hepatectomy. Infusion is usually continued for less than 48 hours. And the two regimens which have been found in literature is that at T7 you give the thoracic paravertebral block, 15 ml ropivacaine, 0.5% bolus each side, and then infusion. Or you can give 10 ml bolus and continue infusion at 6 ml per hour for about 24 hours. Continuous wound infiltration is another option which is available for analgesia via the catheters which are placed at the end of surgery. So different concentrations of ropivacaine are also used in this, ranging from 0.75% to 0.3%, and the bolus varies from 10 ml to 40 ml bolus also. And the infusion usually it is between 4 to 5 ml per hour, which is the common thing, but there is one study which has shown 8 ml per hour for used for over 96 hours. Then post-operative interpleural local anesthetic injection of levobupican infusion is also been used in some case reports. So to summarize the analgesia for donor hepatectomy, you should have an effective pain management strategy. It's an ongoing research and collaboration in the field of transplantation medicine, which will help in devising your strategy and further improving the outcomes. Blended multimodal approach is the common thing which is followed now. It all depends on the degree of pain experienced and the invasiveness of the procedure, the surgery, incision, whether it is robotic, minimally invasive, etc. And we must maintain the balance between the efficacy and the adverse effects of the drugs which are used. So these are my references. The first one has almost everything has been described in that, and there are some meta-analysis available in the last one in which they have compared different strategic concentrations as well as the bolus and the rates of infusions. Thank you very much.
Thank you, Dr. Prerna. That was really an extensive, detailed description of all the available pain management strategies for donor hepatectomy. And in fact, we'll at the end we will see that we'll ask a question like which is preferred over what and why, right? So from donor now we will move on to the recipient. So recipient, the liver transplant recipient surgery is one of the most high-risk surgery with major hemodynamic shifts and coagulopathy and causing massive bleeding, leading to metabolic derangements along with multi-organ dysfunction. And anesthesia for liver transplantation requires a deep understanding of the pathophysiology of the liver failure and its multi-system impact, as well as proficiency in advanced hemodynamic and coagulation monitoring. And it is to be a team approach. And we have seen that dedicated transplant anesthesia teams leads to improved patient and graft outcomes. So now we have Dr. Annu Sarin Jolly. She is Senior Director, Liver Transplant and GI Anesthesia at Medanta, the MedCity. And I know that actually the topic is like a Netflix series, right? Anesthetic management of a liver transplant recipient. But we have asked her to give us just a trailer in 20 to 25 minutes about how one should go about managing. Over to you, Dr. Anand. Yeah, your screen is visible. It's full screen. Dr. Anu, you're muted. Dr. Anu, you can unmute yourself.
Yeah, I've unmuted. So just 1 minute, please. I'm visible and audible now?
Yes.
Both visible and audible on screen
Yes.
slideshow. So I was just thanking the organizers for giving me the chance to speak. And good evening, Dr. Jaya ma'am, my mentor, Dr. Pandey, who's taught me liver transplant, Dr. Prem, who has been my senior in liver transplant. So the topic, as he mentioned, is indeed a big one. So I'll attempt to dive into it straight away without much ado. And for my junior colleagues, so anesthetic management of liver transplant recipient. So Dr. Prem has advised me to cut down on the pre-op management, and I will do so. So rush through first initial slides. But as we all know, any good anesthesia, the background is the pre-op optimization and assessment. So when we are looking at these patients, what are the questions to ask when evaluating a liver recipient? Of course, the severity and the prognosis of the underlying liver disease, like any other surgery, assessment of medical and surgical conditions, and these patients are very sick and they have to be optimized. But how much can they be optimized is a very time-sensitive question. So that is the call has to be taken. This is a suggested form for PAC. So the subjective criteria we all know are, I think all the young colleagues are familiar. These are the subjective features of liver failure, like splenomegaly, bleeding, varices, etc. There have been some objective markers specified for CLD to bring some, to be able to understand who are the patients to transplant. So the CTP score was originally designed to predict mortality following surgery, and later on it became a useful parameter to determine the severity and prognosis of liver disease. This again, most people are familiar, and these are the parameters. Another parameter which is very important is the MELD score, or the model for end-stage liver disease. This is calculated using the serum bilirubin, INR, and creatinine level. This is a logarithmic calculation, so it is done online. The range of the score is from 6 to 40, and as of 2002, the MELD score is used to prioritize organ allocation for liver transplant, where cadaveric surgery is more important. Otherwise, we use it to see how the patient is progressing and just decide on the liver transplant. The etiological diagnosis would be important, like hepatitis B and C should obviously be negative. An alcoholic should be abstinent. If there is a non-alcoholic fatty liver disease like NASH, then we have to work on the comorbid conditions like diabetes, obesity, and hypertension. What are the common symptoms of a liver disease? Ascites, universal, and we have to see in this ascites whether it's poorly controlled, whether there have been multiple large volume paracentesis despite maximal diuretics. There is an infection of the ascitic fluid, which can be quite common, called spontaneous bacterial peritonitis, in which the abdomen would be tense, tender, there would be raised counts and fever. GI bleed history has to be elicited, and we must know the last date of endovaricose ligation, because that could predict the risk of varicose bleeding intra or influence the decision to introduce the TEAD probe. Hepatic encephalopathy is a diagnosis of exclusion, and we are aware of the grades of encephalopathy. We watch out if there is any progression in the grade of HE, or whether the patient has HE or not. Coming on to the diagnostic panel, the routine CBC, LFT, RFT, viral studies, the DIC profile, that is FTP and fibrinogen, inflammatory markers like CRP and procalcitonin, ABG, and cultures, and cell counts of body fluids like pleural and ascitic. Now, kidney, it is important to remember, is commonly affected during advanced liver disease, main mechanism being a hypovolemia leading to SNS activation and activation of the RAS system. So patients with cirrhosis are prone to developing acute kidney injury. And just to familiarize you, the name is hepatorenal syndrome, is a specific form of AKI which carries an especially high mortality risk. The good part is, if it is recognized early, we can administer some splanchnic vasoconstrictors, etc., which can help to reverse the AKI, and it may serve as a bridge to liver transplant. Next is hepatopulmonary syndrome. Just to familiarize you, this is a unique kind of, एक second. This is a unique kind of hypoxia in which there is flatipnea, that is increased dyspnea when patient is sitting upright, and it is relieved when the patient is supine. Or there could be orthodeoxia, in which there's decreased PA. This is the ABG, SpO2 counterpart of it. Another, just to be familiar, there's something called portopulmonary syndrome, in which there is a pulmonary hypertension, which you don't have any other cause for. I will skip this slide. Hepatic hydrothorax is commonly seen during liver transplant, and this is just accumulation of transudative fluid. You do not always tap it, but if it is very large, it could lead to some respiratory compromise. In cardiac evaluation, just we need to see if there's a CAD, if there are any risk factors that could dictate the further investigations. We need to decide whether we go in for medical management versus coronary revascularization, which has its own share of problems in these patients. And if the patient is at a very high risk of MACE, then we may need to delay the surgery. So these are the usual risk factors, and I'm skipping this algorithm. Cirrhotic cardiomyopathy is another word to be familiar with. This is an echocardiographic diagnosis as of now. and it is unique to liver disease patients, and there is chronotropic incompetence. Infections, just suspect them in all patients, and they should be aggressively treated preoperatively. Coming on to the day before the surgery, look for any potential issues in the recipient like fever, new onset breathlessness, pain in the abdomen, or cough, or do the routine investigations again. And we also do a day -1 echo to see if there is any rise in pulmonary pressures or any change in the echocardiographic findings. Coming finally to the intraoperative management of liver transplant recipient, which is a marathon session generally. So preoperative optimization and risk assessment is extremely important. Functional, nutritional, biochemical, systemic, and psychosocial. Psychosocial, why they need to give up on addictions, should be, able to take on their immune suppressants in the post-op period. So this is a multidimensional and multidisciplinary field. So how do we prepare for it? We have to prepare for RSI, that is rapid sequence induction, because there could be delayed gastric empty, there's a tense ascites, encephalopathy, impaired reflexes. So standard fasting, though we advocate, avoid anxiolytics because it could provoke a HE. Continue your usual drugs, and as per the institutional protocol, arrange for an adequate number of PRBC and other blood products. Now, before any procedure, there is always this confusion. The patient might be having a count, say, of 30,000 or 40,000 platelets. Should we correct that? Should we give FFP each time? Remember, liver is, in advanced liver disease, there is a rebalanced coagulation. So it's not necessarily that he's a bleeder. It's a rebalanced coagulation despite low platelets. Along with the decrease in the coagulation factors, there may be an increase in von Willebrand factor or decrease in ADAMS, which could again increase the von Willebrand factor activity, etc. So it's probably safe to do procedures even with a count of 20 to 30,000, or see the TEG or this thing, more of which I'll talk about later. But you do not always have to correct it and bring it to a more than 1 lakh or something like that, or more than 50,000 and INR of 1.2 as a name. That is not possible. So the OT definitely needs extensive preparation. So you need a dedicated spacious OT with laminar flows interconnected preferably, standard monitoring along with CEVC plus minus PA catheter plus minus TE, and fibrinogen availability, prothrombin complex concentrated availability, sonocyte for guiding your lines, advanced cardiac output monitors, point of care coagulation testings like thromboelastogram or ROTEM, warming devices and rapid infusers, and various drugs and infusions. Intravascular access, that is your lifeline. We usually go for the IJV under sonographic guidance, and it is for the purpose of giving massive amounts of fluids, drugs, vasopressors, CVP, secure them properly. And of course, there's a risk of hematoma, so experience and ultrasound guidance is needed. And you can put a HP catheter in some institutes, or you can put, some people prefer to put a sheath through which you can also float your PA catheter in selected cases. So radial, depending on the institutional preference, a radial artery line may be inserted under LA, or it could be post-induction. This is vital for, everything, all your invasive monitoring. A femoral arterial line is also put by some centers, and being femoral SVP being a little higher than radial, and this may be preferred during reperfusion phase, but studies have shown that MAP in adults at least is more or less similar by both routes. And a lot of people would be very apprehensive of the risk of a femoral arterial patient line in a patient with coagulopathy. Induction of anesthesia should be smooth. There should be hemodynamic stability as far as possible. RSI I have mentioned, propofol, thio can be used. Succinylcholine, unless hyperkalemia, most centers anyway have moved away from succinylcholine because of other reasons. Rocuronium is the preferred intubating agent. Cisatracurium for maintenance because it's organ-independent elimination. Antibiotic prophylaxis, repetition, upgradation, antifungals. Please make a chart and make sure it goes in. And of course, padding is important to prevent neuropraxia. As you can see, all the syringes and all these, none of these should get disjointed the 3 ways, and they should be neatly labeled. Now, what is the need for hemodynamic monitoring that I've been emphasizing on? Because there are rapid shifts in preload, cardiac output, SVR, and we need advanced hemodynamic monitoring. And this differs in the various phases. The phases being dissection phases from start of incision to the clamping of portal vein, anaesthetic from clamping of portal vein to unclamping of portal vein, that is reperfusion, and neohepatic is when the liver is new and it's vascularized, like it's been plumbed. So during the dissection phase, obviously there's ascites leak and there could be major fluid and blood shifts because of this leaking. During anaesthetic phase, there would be decreased cardiac output due to clamping of IVC. And neohepatic phase, there could be decreased SVR arrhythmias and decreased contractility of the heart. During for the CBP monitoring, as mentioned by during the donor hepatectomy also, we are targeting low as per IRAS protocol. So for liver, we take a moderately restrictive regime, and for dissection, probably 5 to 7 is okay, though trends are the more valuable. So during dissection, it would help to minimize the transfusion need and improve the visibility for surgeons. And just remember that there's a poor correlation with cardiac output in cirrhosis due to hyperdynamic circulation. So the various cardiac output monitors, just to briefly go over them, we have this flow track Vigilio or the Hemosphere. So this is the one that we are more commonly using. This just needs a radial arterial line, does not need any calibration. It's simple to use. Accuracy may be uncertain in vasoplegic states. Again, the trends are quite useful. PICO we are not using. So this needs a femoral arterial catheter as well. Give some additional parameters like GEF and extravascular lung wall water. Again, femoral arterial line in a coagulopathic patient may be a concern. A Swan-Ganz catheter is, of course, the gold standard. It relies on thermodilution. However, of late, the trend has become a little, less popular because we have other monitors which are giving us more or less a correct picture. And it also has propensity to cause ventricular arrhythmias. T is also kind of optional. It has the advantage of direct estimation of cardiac output, LVOTO, intracardiac thrombus identification, but risk of bleeding with varices and expertise is needed. So there's a lot of coagulation challenges in these patients. Dissection phase, as I said, there's major blood loss. So there could be dilutional coagulopathy and also enhanced fibrinolysis. During the anaesthetic phase, there's decreased synthesis and clearance of coagulation factors and decreased clearance also of the factors leading to hyperfibrinolysis, which can continue into reperfusion. During neohepatic phase, there could be a risk of uncontrolled bleeding initially because of hyperfibrinolysis and thrombocytopenia due to platelet sequestration in the liver sinusoids, that is the new graft, and heparin-like effects from the donor liver. This would gradually resolve, and that would tell us that the liver is functioning. Now, how do conventional coagulation tests, how are they very impractical in a liver transplant? First of all, the standard lab tests like the INR and APTT, they're not real time. They're not available at the point of care, so there's a turnaround time. They do not assess the clot strength. They cannot detect fibrinolysis. They are not very good with platelet function. They cannot tell us a targeted transfusion. And as I mentioned, point of care usability is not there. So all these are overcome by either TEG or ROTEM. So in this slide, in this presentation, I'm focusing on TEG. So what are the this picture is actually showing a hyperfibrinolysis, that is a teardrop this thing. So we have the various times. The reaction time is the time to initial fibrin formation. Decay is the speed of clot. Alpha angle is the rate of clot. MA is the maximum amplitude of the clot, and lysine is the percentage of lysis at 30 minutes. This helps us in guiding towards the goal-directed. What products would you prefer to give? PRBC, naturally, if there's anemia. FFP, if the R time is increased, or there's active bleeding, and there's a volume also that goes with the FFP. If you want to avoid that volume, we can go for PCC, and it's faster effect, but there is also a risk of thrombosis in the post-op period. So a titrated dose would have to begin. Cryoprecipitate, again, contains fibrinogen, factor 8, 1 milligram, and factor 30. And fibrinogen concentrate, synthetics are also available, which can allow us to give us lower volume, and they lack factor 13 and BWF. Platelets are given if MA is reduced, and avoid them before hepatic artery anastomosis, because that is a time then that we do not need a very hypercoagulable patient. Also, they also carry the risk of some, because they don't have, they have to be used within 24 hours. So they have a risk of bacterial infection. Coming on to the fluid management goals. As I said, moderately restrictive, maintain perfusion, avoid overloading. Otherwise, graft will get engorged and later on there will be pulmonary problems. So anaesthetic phase may need a little higher CVP because there would be cable clamping if it is practiced. And during reperfusion, there is a risk of vasoplegia and RV dysfunction. So cautious fluid boluses and move on to vasopressors more. This I think I've already covered. So if you're giving too restrictive fluids, then there's the risk of hyperperfusion and HAT. What is HAT? HAT is hepatic arterial thrombosis. And excessive fluid, especially in all abdominal surgeries, carries the risk of edema to the liver, graft, and lungs. So go on for goal-directed therapy based on the phase, patient status, and surgical techniques. And use vasopressors early in vasoplegia. What is the preferred fluid? It is a balanced salt solution. We prefer plasma light, which is closest in plasma to osmolarity pH. Avoid lactate because liver cannot metabolize lactates. And saline carries the risk of hyperchloremic acidosis and AKI. Plasma light also is compatible with blood products due to lack of calcium, so no clotting in the veins. And colloids like albumin can be used. Hence is starch based and it is to be avoided due to risk of nephrotoxicity generally. Which are the various vasopressors? Norepinephrine, drug of choice. Phenylephrine, pure alpha-1. So there is not much tachycardia, so small boluses work better. Epinephrine close to reperfusion. Ephedrine, small boluses may be needed. Then coming on to vasopressin and terlipressin. So these are splanchnic modulators. Now terlipressin is the synthetic analog of vasopressin with more selective action on V1A, longer action. And they help to decrease the portal pressure by constricting the portal vein, and they can also be help to elevate the blood pressure. Others are methylene blue in refractory vasoplegia. Milnidrone hardly ever used. It's an inodilator. And what are the complications of excessive vasopressors? Hyperperfusion, dysrhythmias, myocardial ischemia, local necrosis, and hepatic microcirculation may be impaired with high-dose catecholamines. Coming on to the electrolytes and acidosis. So hypocalcemia, because of chelation of calcium burst in anaesthetic stage. So monitor it, and this will improve as the liver is reperfused and the new liver can metabolize citrate. Hypokalemia might be because of poor intake and chronic diuretics. Hypokalemia may be because of massive blood transfusion, renal dysfunction, or during the reperfusion phase. Then hyponatremia is common because of dilution, and do not attempt to correct it rapidly. Hypomagnesemia, same as calcium. Chelation. Metabolic acidosis is because of loss of hepatic metabolism of acids during anaesthetic stage and acid load from the transfusion and hypoxic tissues. So glucose has to be monitored. There could be reduced glucose synthesis in the anaesthetic stage, especially in ALF patients. We see this, and hyperglycemia may follow reperfusion because of and persistent hyperglycemia is not good. So hypothermia, one has to vigilantly watch for. It worsens coagulopathy, increases infection risks, and delays recovery. Reasons being naturally large surgery, cold solutions, cold fluids. So prevention is the best. And monitoring through the various core temperature monitors, again, PA catheter being the gold standard. Just to review and summarize. So dissection phase, as I said, starts with incision. There's drainage of ascites. Vasodilation may be there. And there's potential for excessive bleeding. Avoid volume overload. Anaesthetic, there is vascular anastomosis. There's cable clamping. So there could be loss of preload because of cable clamp. So when you and hyperkalemia may need aggressive treatment to prevent hyperkalemic arrest during reperfusion. And there could be worsening acidemia, as I said. So during reperfusion, what is reperfusion? When there is the portal cable clamp is released, and it could lead to a portal reperfusion syndrome, that is decreased of mean arterial pressure more than 30% for more than 1 minute within 5 minutes of reperfusion, which could lead to hyperkalemia, hypotension, pulmonary hypertension, RVF, cardiovascular collapse, and thromboembolic complications. The neohepatic phase is when the liver has started functioning, and we do the surgeon does the HA anastomosis that time, biliary anastomosis, hemostasis, and closure. So adequate graft function, what are the signs of adequate graft function? There would be graft dysfunction would be indicated by persistent or increasing vasopressor requirements, increased arterial lactates, decreased urine output, worsening of persistent coagulopathy, And the reverse of it is telling us the graft is functioning. The major complications are, of course, massive blood transfusion, intracardiac thrombus, refractory vasoplagia, post-perfusion syndrome, massive air embolism. So towards the end of the surgery, the surgeon does a Doppler to confirm arterial flow. The patient has to be shifted on monitors and all the infusions. A proper documented handover must be given. Fast tracking may be an option in selected cases. Pain, like as they mentioned for donor, is usually not that much for these patients because they're asthenic, muscle depleted. The ascites has stretched the muscles a lot. So generally we can deal with Ventolin boluses, limited paracetamol. In some patients, selected patients, we even use the IV-PCA. So ICU is the continuum of all this care, aggressive physiotherapy, as you can see in this picture, mobilization of patients and immune suppressants. Thank you.
Thank you, Dr. Annu, for comprehensively covering such a vast topic in such a short time. However, all the salient points were covered. And I hope that all the newcomers will also be have been enlightened about how to go about managing a liver transplant recipient. Now the house is open for discussion. So we had questions in the chat box. So the first question is epidural not preferred in open donor hepatectomy? Dr. Prerna, would you like to answer? Please unmute yourself, Dr. Prerna.
Yeah. So it's not that it is not preferred. In fact, in our institute, we still pass the epidural catheter. So if you have other options and you are used to using the tap block and other things, it is helping. And also in some institutes where they are now going to laparoscopy and robotic approaches for donor hepatectomy, in those patients now epidural is more or less not inserted. But however, we still insert epidural catheter. It's not that it is not done.
Dr. Annu, what is your take on this question?
So I think epidural has been like, give the dog a bad name and hang him, literally. It is a lifeline. It's a big incision. Really nothing else works if it's an open donor. And in cases in which sometimes our patients have refused epidurals and all, so we have found this external oblique intercostal muscle block quite okay. Either our end or we tell the surgeon to give it. So it's a volume facial pain block again for upper abdominal. And of course, we give IV-PCA to all our patients. Regarding the concern for epidural removal and INR and all, as I said, this is again more on, many papers have been presented, including you, Dr. Prem, have presented it internationally, that INR is not a sole guide for, epidural removal. If there is a doubt, you can go in for a 10, you'll often find these patients are actually hypercoagulable. So if you're just following that, and how many patients, like we've done so many donor, we've never had a problem of epidural hematoma or, like really delayed epidural removal. So I think pain in these patients should not be there at any cost, and catheters also can get dislodged. And for robotic, yes, robotic, of course, you don't need all this, but robotic also we've discovered that, as she said, Dexmet and TIVA has somehow, preliminary presentation only by the department, but TIVA has somehow helped with the post-op pain also. So let's see about that. Dexmet is there, and we give IV-PCAs to our patients.
Is our mentor Dr. Pandey sir is there?
Dr. Pandey, unmute yourself, sir.
Dr. Pandey sir or Madam Sood Madam, what is your take on epidurals for donor hepatectomies in the current scenario? I think they are not there. Okay.
I think they have to unmute. Maybe the technical team can unmute it or something.
Dr. Pandey sir, can you unmute yourself? Madam Sood? Okay, so let's go
Hello,
to the next.
Prem. Anji?
Yes, ma'am, we can hear you now. So
Yeah,
we
yeah.
wanted to know your take on epidurals for donor hepatectomies.
Donor, my take on?
Epidural for donor hepatectomies.
Prem, you know very well what we were doing in our hospital initially and how we had to change. So really, of course, what we prefer is definitely there. Donor is a very good option, especially if it's open. The epidural is a very good option if the donor is open. But sometimes the surgeons, since we always interact with our surgeons, some surgeons for some fancy reason of their own prefer not to put an epidural. So of course we discuss with them. So if everything is fine, we do give epidural. Otherwise, of course, as you know, we have very good, as Prerna said, very good regional, not epidurals, but other regional blocks and other agents that can be used. So both the options are there, and we are drifting away from the epidurals.
Right. So, Dr. Pandey sir, are you there? I think.
Hello, yeah.
Yeah, hi sir, how are you?
I'm good,
So
yeah.
you are our mentor, right? Dr. Vijayavara sir. So what is your
Yeah.
take on epidurals for donor
Yeah, with the
hepatectomy
passing
in
days,
current
with
scenario?
the Dr. Prem, with the passing days, now previously we were using the epidural as a sole analgesic agent for the post-operative analgesia. Now, over the period of time, TAP, this one, rectus block, and intercostal blocks have come up, and the patients are really getting better results with this one. I cannot deny the epidural was bad, but the newer one, ultrasound guided, this one, we are getting the much better results. So I think according to the situation, we can go with the epidural or otherwise with the specific blocks.
Right, sir.
Yeah.
So, Dr. Sunil, just highlight what are the main challenges which one faces, which are different in minimal access surgery as compared to open donor hepatectomies.
So the minimal invasive donor hepatectomy, main thing is like the lot of equipments and surgeons involved will be there, sir. So there'll be less space for the anesthesiologists as well as the anesthesia technicians who will be helping us. And another thing is the head end will be occupied by the surgeon's screen. So we won't be able to have access at the airway or any other lines related issues which we take care of generally in open donor hepatectomies. Other things is because of long duration surgery, there will be chances of hypothermia and pressure sores, which if we don't take care at the beginning of surgery, when we open the drapes, we will find out all these problems being there. Third thing is the pneumoperitoneum, which is being caused during donor hepatectomy. That causes other challenges like the airway pressure going up, or sometimes bradycardia happening, or hypotension happening. Even the position of the patient, when we keep him the head end up and reverse Trendelenburg position, there will be drop in blood pressure, which we need to counteract it. At the same time, not give much fluids during the surgery. Sometimes in few cases, like when they are retrieving the graft, which we used to face, but luckily because of sir, we used to take care of those things, that when we are removing the graft, there will be complete relaxation of the patient should be there. Otherwise, the surgeon wouldn't be able to remove the graft from the pharyngeal incision because of the muscular layers at the pharyngeal mark. So these are the few anesthetic challenges which we face compared to open donor hepatectomies.
Dr. Anu, you have been doing robotic hepatectomies. So what are the challenges different from minimal, that is laparoscopic to robotic hepatectomies?
Robotic gives you a better, like laparoscopic, the hand mobility only for the surgeon. It was not there, so it used to go on much longer. I think robotic probably with the 7 degrees of movement and all that, they're doing it very fast. They could never reach that efficiency with the laparoscopic. I think the equipment itself helps. And like for our, because slightly we have bigger theater, so our slave monitor is on the side and we are at the head end very much. We don't leave our head end. And so that is there. And I was very, like, I don't know this, somebody I think from the Southeast had put LMAs in donor hepatectomy. That's quite ambitious.
Yes,
With
yes.
your pneumoperitoneum and everything, one end, I don't know, it's just being a little too ambitious according to me. And we are using ordinary tubes, we are not using reinforced tubes. I mean, that's a personal choice. That's no harm in being cautious, extra cautious. That's what I was just trying to say. LMA to normal tube to plexometallic, that's quite a thing. But our technicians are now trained, so the splitting of legs and everything is very fast.
I want to know how often have you converted and what were the problems in converting from robotic to open surgery?
No, we have no. I have not seen conversion. I mean, I've joined here and I'm doing robotic for now 7-8 months. I have not seen, and from the history, what I have, hardly any conversion. Never converted him. No, none of those learner phase problems, which like AI or something. Never. In fact, the robotic is a go-to default mode unless the robot is not available or there is some financial constraint.
That's all the questions from the chat box. So, Madam, are you there?
I'm there, Prem.
Yes, ma'am. So I would request you to give the vote of thanks. And I personally would like to thank you and the Indian College of Anesthesiology and Dr. Angelina for giving us the opportunity to present about liver transplant anesthesia in this forum, and would like to be part of this in future also. Thank you, madam. Please.
Of course. Thank you so much, Prem. That was really good. And thanks for being the moderator for this very, very special and important session. And you all are the stalwarts. You, Annu, Prerna, Dr. Sunil, all of you. And I'm so happy that you could take out time and contribute and conduct this webinar. That's excellent. And it's nice that, that I've been associated with you and Annu for a very long time. And Prerna, of course, I know also for years. Dr. Sunil as well, although I haven't met him many times. So this webinar for the students was so informative. And as has been discussed so well, that there are so many, the changes are dramatic that are taking place. But basically, the physiology has to be understood and the steps of the procedure, anesthetic and surgical procedure, both have to be understood, whether it's open or whether it is laparoscopic or robotic. So each technique has to be understood by the anesthesiologist. So besides being a very high-tech surgery, robotic itself is also high-tech, and we need to know much more about robotic before we really jump into providing robotic anesthesia. So with these few words, I would like to thank all of you, Prem, Sunil, Annu and Prerna. Thank you so much once again. And thank you, Saloni and Vineet, for being there to make sure that there are no glitches. And thanks a lot, Rimpa, from the Clarinet. Thank you so much. And we do hope to see you all in the ICA webinars as well as the conferences. As you all know, that the ICA Con 2025 is going to be held next week in Jodhpur. And we would be so happy to see you all there. I know you have a very busy schedule, and the students who are listening to this webinar. Thank you very much and good night.
Thank you.
Thank you so much, ma'am.
Thank you
Good
so
night.
much, ma'am. And thank you so much, everyone, for joining this session. Clarinet is really glad to have all these brilliant people together. So with all your permission, shall I close the session for today?
Yes, Rampa.
Yes, ma'am.
Thank you,
Thank you so
everyone.
much,
Thank you,
ma'am.
ma'am. Good night.
Thank you. Good night. Hope to see you soon. Bye-bye.
Yes, ma'am.
Thank you.
Bye.
Thank you.
Bye.
Thank you, Doctor.